Hello, everyone. Thank you for joining us at the Global Cardiovascular Forum 2023. My name is Dr. Ajith Nair. I am a cardiologist and an advanced heart failure cardiologist specializing in cardiac transplantation and mechanical circulatory support. I'm part of the Baylor College of Medicine. I'm also part of the professional staff of the Texas Heart Institute. Today I'll be talking about innovations at the Texas Heart Institute, improving access to heart transplantation. First of all, we can review our advanced heart failure stages. Stage A are those patients who are at risk for heart failure, including those with hypertension and diabetes. Stage B are those patients who have structural heart disease but don't have clinical symptoms. Stage C are those patients that we commonly see, those patients who have structural heart disease, and these patients are candidates for guideline-directed medical therapy. Over the last 2 decades, there has been an advancement in both medications as well as device therapy for advanced heart failure patients. But there is a significant portion of patients who fail all of these therapies and go to stage D heart failure, which is medically refractory heart failure. There are certain signs and symptoms that may prompt referrals to advanced heart failure centers. One mnemonic is the I need help mnemonic, and these are patients who require inotropes, those patients who have advanced New York Heart Association class or consistently and persistently elevated natriuretic peptides, those patients with end organ dysfunction, including the cardiorenal syndrome, significantly low ejection fractions, defibrillator shocks, recurrent hospitalizations, escalating diuretics, low blood pressures, as well as failure to stay on guideline-directed medical therapy. There are other additional ways to look at patients for advanced heart failure referral. Something that we commonly do at the Texas Heart Institute and Baylor is cardiopulmonary exercise testing. Data from decades ago showed that ejection fraction did not always correlate to survival. However, peak VO2 as well as VE/VCO2 can predict outcomes in heart failure patients. This is something we commonly do as cardiopulmonary exercise testing to risk stratify patients. If you look at the United States, there's about 5.7 million patients who have heart failure, and up to 1.5 million are in the advanced heart failure stages. At least 25,000 of these patients are appropriate candidates for advanced heart failure therapies, including cardiac transplantation and mechanical circulatory support. However, up until this time, it's estimated there's only about 3,200 donors available for heart transplantation each year. So the supply of donor hearts is limited, and heart transplantation has not always been an option for all patients. And over 270,000 patients die of heart failure in the United States every year. So this is a growing pandemic, especially with the increase in age of our population and increase in risk factors such as diabetes and hypertension. So we look totally, 25,000 patients are appropriate candidates for advanced heart failure therapies, but we are limited with organ supply. Now in 2018, the listing transplantation criteria changed, and this was really sort of an instrumental change that occurred in the United States, and a lot of it was due to our very own Dr. Joe Rogers, who chaired the committee that looked at changing this criteria. We list patients from status 1 through 6, 6 being those patients who may be candidates at home, 5, those patients who are waiting for potentially another organ, say a dual heart kidney offer. 4, those patients who have LVADs or those patients who are at home on inotropes. Status 3 are those patients who are typically in the hospital on inotropes or have some sort of complication with their LVAD. Status 2 are those patients who may need intra-aortic balloon pumps or axial flow devices such as an Impella. And status 1 are those patients who are the most sick and in most dire need of transplantations. These patients are typically in the hospital on veno-arterial extracorporeal membranous oxygenation support, or VA ECMO. So this criteria change has been revolutionary as far as allocating organs to the sickest patients on the list. If we look at survival in the United States over the last several decades, this has also increased. And I think there are multiple reasons for this improvement in survival: better donor selection, better recipient sort of selection, as well as improvements in immunosuppression, as well as the heart team approach as far as caring for these patients before and after transplantation. Overall survival has increased, and so our 1-year conditional survival is typically upwards up to about 90% in most patients. And if we look at etiologies, most patients who are referred for transplant do about the same, although those patients who have congenital heart disease over the 1-year period typically do better than those patients who may have multiple comorbid conditions. Now, one of the things that has helped reduce adverse events is organ size matching. And this has helped improve 1-year survival as well as 5-year survival in all patients. Shown here is the organ recipient size matching algorithm that we use as the Texas Heart Institute. This looks at patient demographics, including age, sex, height, and weight, and we were able to calculate an estimated donor mass or heart mass, and we're able to match donor as well as recipient. And we found that here at the Texas Heart Institute, we have also increased our survival rates using this matching formula. In addition to that, one of the innovations that has come about over the last several years is the use of hepatitis C donors. Traditionally, we did not use hepatitis C donors because the recipients invariably would contract hepatitis C. However, with the advent of pangenomic hepatitis C therapy, this has changed. And this was an article that came from several of former Texas Heart Institute surgeons looking at heart and lung transplantations from hepatitis C infected donors to uninfected recipients. And here we've done this at the Texas Heart Institute, where we've taken patients who have not had hepatitis C, used a donor with hepatitis C, treated them with pangenomic therapy, and this has completely eradicated any hepatitis C that we see in the first 2 weeks after the recipient contracts hepatitis C. This has allowed for increased usage of donors, and typically these donors are unfortunately young. They may be patients who are part of the heroin epidemic, and unfortunately, despite this, these are donors with good organs, and we've used this successfully at Baylor St. Luke's Medical Center as well as the Texas Heart Institute. Another sort of newer development in transplantation has been the use of organ care systems. And shown on the left is a pictorial from a 1963 article looking at perfusion of a heart-lung block. And so this concept of perfusing an organ up until transplant is not novel, but it was embedded in sort of the early transplantation literature. Seen on the right is the TransMedics organ care system. And this is a system by which an organ can be actively perfused after it is obtained from a organ site. And this active perfusion allows for careful monitoring of the organ and transport for far distances, say 1,000 plus nautical miles, to our center. And this is something that we not only have that's an ongoing program at the Texas Heart Institute, but our very own Dr. Ken Liao has done significant research on the OCS as well. And typically we look at coronary perfusion as well as lactates to judge organ viability, and this allows sort of an expansion of the area that we can procure organs from the organ care system. Another method to increase the donor pool has been altering the method of organ procurement. The traditional method is donation after brain death. This is the typical way that organ transplantations have been done in the United States. Here, a donor is declared brain dead, the heart is evaluated, there's procurement, and there's preservation on cold static storage up until the point of transplantation. Now, this has changed with donation after cardiac death. Here, the donor has life-sustaining injuries, and there's withdrawal of life-sustaining therapy. There's a period of hypoxemic cardiac arrest that occurs, ultimately leading to circulatory arrest, typically anywhere from 5 to 10 minutes after the withdrawal of support. There's circulatory death, and then procurement. Procurement can be done on cold static storage, and unfortunately this can typically lead to issues with ischemia of the donor up until the point of transplant. So another method has been to actually use organ care systems or other methods to actually reanimate the organ and allow for improved outcomes. And this includes ex situ heart perfusion. So this typically is in two methods. One is the direct procurement and machine perfusion, where there's withdrawal of support, declaration of circulatory death, aortic cross clamp, and on the back table, the organ is placed on the organ care system, perfused, and then ultimately taken to our center for implantation. Another method is the direct procurement and normothermic regional perfusion, where there's withdrawal of support, declaration of circulatory death, reperfusion using cardiopulmonary bypass, and then transport on cold storage up until the point of transplantation. So these are two methods for using organs that are DCD donors. So this has really changed our pathway for transplantation. So the traditional pathway included donation after brain death, but here now we have donation after circulatory death, or DCD donors, and that can be done through the organ care system or using cardiopulmonary bypass to reinvigorate the organ. So this has really led to an increase in U.S. heart transplant volumes. So DCD is not novel. In fact, the first transplant done in 1967 by Christian Barnard used a DCD donor using normothermic regional perfusion. So this is not entirely novel, but improvements in sort of our organ transport systems has really brought this back to fruition. And if you look at the US and UK survival for DCD, the 30-day survival is 97 to 100%, and the 1-year survival is 91 to 98%. I want to thank you today for being part of the Global Cardiovascular Forum and exploring innovations in changing cardiovascular care. My name is Ajith Nair, and if you have questions, please email me. Thank you.